Thank you so much for asking me to speak today. This is a topic that I think is underrepresented oftentimes, and we've realized now that it's probably a little more important than we thought in the last 20 years of research for 22q, and so it's kind of nice to have a forum to be able to discuss these ongoing issues. So some important things I want to talk about, as I mentioned, our understanding of 22q and other 22q-like syndromes is evolving. Mostly we talk about early findings when we talk about 22q. And in terms of the immune system, but we are realizing now that that's not the end. So we thought maybe once you hit about 1 year of age, we've cleared you for what you need to do, and then you don't really need to ever see us again. But we're realizing now as our population ages, we're doing a better job of keeping them healthy, that we're finding that issues can come back, a lot like some of the speech issues, or things that never happened early on will happen later. So we've realized that we need to do a better job of surveillance. So before I can talk about what happens in 22q, we're going to have a little lesson on your immune systems. You'll have to excuse me, we're going to get a little bit technical, but it'll make a lot more sense as we go along. So your immune system is your defense. That's the number one way to think about this. We talk about, perfect. So the immune system starts with two main components that we'll discuss. The one side is called the innate immune system, and the other side is called the acquired or adaptive immune system. The innate immune system is by far our biggest part of our immune system, and the number one component of that are the physical barriers. So those are things like skin, mucus surfaces like inside your nose or the lining of your lungs. These are the first defenses to fighting against mostly bacteria, but also viruses and fungal infections as well. The basic blood defenses that we talk about are kind of our basic cells, known as your red blood cells, your neutrophils, your eosinophils, all of these things that help us mount responses to infections. And then what I mostly talk about is the acquired or the adaptive immune system, which includes B cells and T cells. And we'll go back into what each of those things do as part of this. It's important to remember where our immune system lives in all of these places. So we find our responses happening in tonsils, in skin, in the bone marrow, in the spleen, and very importantly for today, in the thymus. So it's important to remember that your immune system starts in your bones. No matter who you are, that's where your blood cells are made. So it starts in your bones, and then it comes out into the circulation. Part of the immune system becomes the innate immune system. So I mentioned those cells. These down here at the bottom are all of the eosinophils and neutrophils. That's part of your innate immune system. And the other part of your immune system is the adaptive response. And that includes B cells and T cells. Why I'm being very specific about this is two reasons. Number one, the thymus is where your T cells go after they come out of your bone marrow, and that's where they mature. And that's where they learn to respond to infections. Without a thymus, your T cells have nowhere to go, and they will not learn to respond, and you will not have any survive, basically. With B cells, when they come out of the bone marrow, they're a little bit more ready. So they don't need to stop anywhere, but they do tend to go to your lymph nodes, and they're the ones that actually produce antibodies. Antibodies that we talk about are IgG, IgA, IgM, and IgE. And the most important antibody for us in terms of fighting infections is the IgG antibody. That's the one we really want to know that you are supported by. So, take a step back. What do T cells do? Why are they so important? Well, as I mentioned before, they protect us from certain types of infections, and they're very specific. They protect us mostly from viral infections and from fungal infections. They also work a lot with the B cells to protect us from bacterial infections. So sometimes when you have a T cell problem, even though your B cells are okay, the fact that they don't work together very well makes you susceptible to both types of infections. They also help regulate inflammation in the body. So they are our suppressors. They kind of go around and do like a little surveillance, and they bring down a lot of inflammation that happens in the body. Or if you have an immune response that is initiated for whatever reason, they're the ones that kind of are the cleanup crew. So they come back around and make sure everything comes back down to normal. B cells, on the other hand, are the ones that make those antibodies, so IgG, IgA, IgM, and IgE, and there's many different subtypes of those antibodies. They work with T cells to fight infections, and then they also protect us from infections with bacteria. So when you have a problem with your T cells, what you're going to see is somebody who has a lot of issues with viral infections and with fungal infections and maybe some bacterial infections. When you have a problem with B cells, you're going to see somebody who has a lot of infections of bacteria. And mostly with B cells, we see infections of recurrent ear infections, recurrent sinus infections, and recurrent pneumonias. That's kind of where B cell issues lie. So what does this have to do with us today? Well, it's kind of interesting. This is some drawings that show kind of in the evolution, the development of a fetus, where the cells actually start. So if we're looking at this blue tissue, this is parathyroid, so this is a different gland, thyroid and thymus. They sound very similar, but they're not exactly the same. The red that develops here is your thymus, so that's important to me, right? That's where your T cells are going to go develop. As you grow in the fetus, as it grows, these two areas separate. So this is your thymic tissue, and this is your parathyroid glands. They move down, and then your thyroid is up here, and that's where your parathyroids go to. And then your thymus is right here, and this pink tissue at the bottom is your heart. The reason this is important is because this migration is affected in 22q. And this can explain a lot of the reasons as to our affectation that we see. So these kids have issues with the migration from a midline location, so they have palate issues, they have parathyroid issues with problems with their calcium, so that's close to this area. They have thymus issues, where some patients may not develop a thymus, although almost all of them do have a thymus, but they have less thymic tissue, and so maybe a smaller area to develop. And then it goes all the way down to the heart. A lot of these kids have heart issues too, right? So this kind of makes a little bit more sense in terms of how these kind of oddly connected things really did come together. So what do we see in 22q? Very specifically, early on, we see T cell affectation for the very reasons I just explained. That thymus is there, maybe it's not functioning as well, maybe it didn't all make it there, maybe it's very small. Your T cells come out to that thymus and are waiting for a place to kind of mature. But when they have these low T cells, and they're affected usually in a certain proportion, what we will see in these patients is that they have a susceptibility to those viral and fungal infections. Because of this susceptibility to viruses, we ask early on that patients hold on getting any of their live viral vaccines, because if you don't have the T cells to mount a response, it's going to be very hard for you to have a good response to that vaccine without actually getting that actual infection, right? Your body's not going to be able to mount a response. They're not going to be able to make some memory to that response and hold on to it for the next time. What'll happen is you get the vaccine and you'll actually get that infection. And so until we know that your immune system is functioning well, we say hold on live viral vaccines. This didn't used to be a problem in the beginning because most of the live viral vaccines didn't come until patients were 1 year of age. You know, that's your MMR and your varicella vaccines. But now with the rotavirus vaccination that's happening much earlier, we're having to have these conversations with people a lot sooner. We also know that kids with 22q can have low T cells, which also includes that compartment of T cell regulators. So these kids have a lot more problems with ongoing inflammation, more than we realized previously. Most of the time, they tend to have normal B cell numbers. So we felt very confident that this was a completely T cell problem. It wasn't a big deal. Once you cleared the T cells, you guys were good. Get your 1 year vaccines and we'll see you if you need us. But the truth is we've realized that even though those T cells aren't low anymore, let's say as they get older, they're still having issues with function, and that really starts to pull in the B cells as well. Remember I mentioned before that they help each other, and so once that T cell isn't perfectly on par, it's going to still have a little trouble communicating with those B cells. We're seeing as kids get older that no, they're not having issues with their T cells, they're not having viral infections or fungal infections, but they are starting to have more bacterial infections. So they'll come in and say, you know, the last few years I've started having ear infections or some sinus infections or pneumonia. Once you have one pneumonia, I'd probably want to look into it at that point. But it's something that can develop as they get older. Now, don't get me wrong, we can certainly see this at a much younger population as well, but certainly we're making it an effort to make more of an awareness that as you continue to age, it's something that you keep in mind. Early evaluation, just to talk briefly about the testing. I feel like sometimes we get into this and we say those big words and nobody really tells you exactly what's going on. We talk about lymphocyte subpopulations, also known as immune phenotyping. And that's basically just looking at the numbers. It doesn't tell you anything else but numbers. So I'm looking specifically at B cell numbers, T cell numbers, and natural killer cell numbers. That just comes on the panel. More importantly, or secondarily, but probably more importantly for vaccination issues, is what we call mitogen proliferation. And this really looks at T cell function. This is somebody sits and takes somebody's T cells and stimulates them and see how well they respond, basically. That really gives us a better idea as to how well you would do getting a vaccination and being able to respond to it. If you have normal mitogen proliferation, I'm not worried at all about your viral vaccine, so your MMR or your varicella. Immunoglobulins, those are your antibodies, so the IgG, IgA, IgM, and IgE. That's a test of function of B cells. So we have our T cell function, which is mitogens, we have our B cell function, which is being able to produce antibodies, and we get a really good idea of how your immune system is working. Later on, I continue to follow patients looking at not only their T cell function, but sometimes, because I know of the risk, I will also continue to look into their B cell function. And sometimes I'll also do some more specialty tests that include not just vaccine responses, how well they did, or looking at general things like responding to their environment, but also looking at memory. So can you make a response and hold on to it? That's kind of important too. Some of these kids have issues with our memory responses. And then finally, I went really quick, huh? Please feel free to stop me if you need to, but finally, one of the risks that we have with our patients is the risk of overdrive. I just call it this because it's a general inflammation / autoimmunity discussion that I have with our patients. Because, again, T cells are a little changed in function in some of these patients. As I mentioned before, we're doing a better job of tracking them early and keeping them healthy. We're seeing as people age that they can start developing some things with autoimmunity. Autoimmunity means that your body actually, while it's not making the best antibodies, the ones it is making are attacking itself. In the irony of it. And so patients will have antibodies that attack their own blood cells, so they can have anemia due to that, low red blood cells. They can have thrombocytopenia, which is low platelets, and have bleeding disorders. They can have arthritis, so these antibodies can actually target the joints. And then also they can have thyroid problems, so the antibodies can target the thyroid as well. These are things that we track over time as part of our regular immune surveillance, and we ask questions about them as well. We know that there's a higher risk overall, so it's something we're looking for every time you come in for a visit. How do we treat this? Well, if you do have issues with infections, we do antibiotics. For some people, they don't get them very frequently, and so we're comfortable letting them just treat the infections as they need to. For others, there's enough infections where they might actually need replacement antibodies, so it is possible to actually give somebody extra antibodies if they need to help them fight off infection. So we have a few patients even now who are getting these monthly, and it makes a big difference for them in terms of the frequency of infections. And then, of course, as I mentioned, the irony, sometimes we need to use immune suppression, certainly in the cases of patients who have issues with arthritis or blood issues with antibodies, where we're trying not only to support their immune system, but decrease the overdrive a little bit at the same time. So, when do we do immune evaluations? Well, hopefully early on upon diagnosis. Most patients tend to have, upon diagnosis, at least a baseline evaluation that we like to see. We like to see the completion of their initial vaccines. That's in the first 6 months of life, basically, the few sets of vaccines they have. It gives us a good idea as to what type of immune response our patients can have. And then usually I like to see them After we've completed the early evaluations, which are usually about every 6 months for a little while, then I like to see my patients about every 2 to 3 years if they are doing very well. And of course, I always make sure that families are aware of these risks that we have, and so I want them to return to see me sooner if they're having issues with infections, for instance, or any sort of arthritis or other issues. Oh, so that was it. With that, I'll say that, like I said, we're kind of coming to a new era in terms of immunology in 22q, and we are able to study now a population that has become much older than other times have had, I guess. And so we are continuing to learn stuff about the immune system more and more, and I always encourage people to come back and see us, even if you're doing well, in order that you know that there's always going to be a baseline to go from if something should happen later on. So, thank you.